Diagnosing rectal bleeding, like any other medical condition, starts by taking a very good history of the condition itself. And when we're asking about rectal bleeding, we want to know a number of facts. We want to know the duration of the bleeding. How long has it been going on for? We want to know whether the bleeding is bright red blood or dark blood. Is there evidence of the blood being altered into clots, combined with mucus, into congealed little lumps that come out? We also want to know the frequency of the bleeding. Is it something that happens every day? Is it happens every week or once every year? The quantity of the blood is important. If it's heavy hemorrhage, that's obviously an important emergency. It needs to be seen and investigated quickly. But if there's occasional spots of blood here and there, this can be diagnosed in time. You can see a specialist and have investigations if necessary. As far as other conditions associated with bleeding, these are very relevant. We want to know if the patient has any other gastrointestinal symptoms. In particular, have they noticed recent change in their bowel habit? This is a very important symptom. A change in bowel habit suggests that there's possibly inflammation, infection, or even, unfortunately, bowel cancer or malignancy. So we want to know if the bowel pattern is regular. Are patients regular? Has there anything changed in the last few months? We want to know whether the patient has lost weight. Do they have any other abdominal symptoms? And most importantly, we want to know a family history. Do patients know if they have a family history of colon cancer, rectal cancer, inflammation, inflammatory bowel disease such as Crohn's disease or colitis, all of which are relevant in us making a diagnosis of where the rectal bleeding is coming from and what the underlying cause is. Once we've taken a full history and we know all this information, a patient needs to be fully examined. And either by the general practitioner or by a specialist, if they're referred to, we carry out a full examination of general patient looking for signs of anemia, other changes of skin color such as jaundice, which might indicate a gastrointestinal problem, and also swollen lymph glands, so-called lymphadenopathy. These are all signs and symptoms of an underlying other problem. We then examine the abdomen fully, and almost always in a specialist clinic, we do a rectal examination using simple digital examination by a finger. And if you are seeing a specialist, almost always we will like to carry out an internal examination of the rectum with an instrument called a rigid sigmoidoscope. This is a painless examination which takes only a few seconds, but gives us information as we directly inspect the lining of the anus and the rectum. Obviously, if your general practitioner is seeing you, they may carry out a digital examination, but usually they will not carry out the instrument examination. And if they feel that you need to see a specialist, they can refer you to a specialist who will do that. In many patients who have simple bright red rectal bleeding and who have no other associated symptoms, we can make a diagnosis in clinic of either hemorrhoid or anal fissure or a simple condition which we can treat or discuss management. But for some patients, we need to investigate further. And these are patients who have come to see us with blood that's darker, blood that's mixed in the stool, and there's mucus or diarrhea or weight loss or other symptoms. In particular, we are interested in patients who are over the age of 40 who may have one of these conditions. And we must not assume that just because there is bright red blood only, there is no other serious problem. Patients over the age of 40 must have at least a rigid sigmoidoscopy, an examination of the rectum. If we then decide the patient needs further investigation, there are a number of options available. The easiest and the commonest available one is a thing called flexible sigmoidoscopy, which is use of a fiber optic flexible instrument, which is carried out in hospital, and the patient arrives on the day of the procedure and receives a simple enema, which is a preparation into the rectum to clear any remaining stool. Once this is done, which takes literally a few minutes, we can carry out a flexible sigmoidoscopy in a special environment in a room called an endoscopy suite. The instrument is capable of examining up to 60 to 70 centimeters of the lower intestine, the colon, rectum, and the anus. And this is very, very good investigation for most patients under the age of 40 who've noticed bleeding. Patients aged above 40 or patients who have any other associated symptoms, such as change in bowel habit, weight loss, or other symptoms, must have a full examination of the intestine, and that is known as fiber optic colonoscopy. For this, patients need to have a full intestinal preparation, a bowel prep, the day prior to the procedure. This involves taking only clear fluids and no solids for a whole 24 hours or a minimum of 12 hours, depending on the timing of the examination. Patients are then given strong medication called laxatives or bowel prep medication, which allows them to pass multiple stools and clear the intestine. Once the intestine is clear, on the day of the procedure, we give the patients usually a small sedation, but sometimes patients require to be sedated deeply. The sedation they normally administer is conscious, the patients are awake and they can watch, but it takes away any discomfort and pain from the gas that we insert while we examine. The procedure usually takes 20 minutes and it is considered as the gold standard of examining the intestine. Through this instrument, we can remove polyps. We can even remove small cancers. We can certainly biopsy the intestine for inflammation. We can biopsy if we see a lump we don't recognize or it's difficult to know what the underlying diagnosis is. And in many patients, this will exclude, obviously, a sinister cause. We can treat bleeding by using laser or argon beam photocoagulation and perform what's called a therapeutic colonoscopy. And patients wake as they leave the hospital, they are left with no discomfort, no pain, and there's very little recovery time. An alternative to this, which is an invasive investigation, is a CT colonography. Sometimes this is known as virtual colonoscopy. This has become very popular over the last decade, and it involves a CT scan. But patients are given a prep, just like the colonoscopy, on the day before the procedure. The prep is gentle, mild, and allows the patient to have a clear out of the colon. And on the day of the procedure, a CT scan is performed, and the doctor performing the scan will insert some air, a gas through a tube into the rectum. It takes literally 10 to 15 minutes and has the advantage of not only looking at the colon and the large bowel, but also other structures around the abdomen, including all the other digestive structures, liver, kidneys, pancreas, and bladder and prostate in men and ovaries in ladies. So it has the advantage of looking at the structures. The disadvantage of this procedure is that it cannot perform a procedure, of course. And if there's a polyp or a growth in the intestine, then the patient needs to have another preparation and a colonoscopy to carry out a biopsy or remove the polyp. Majority of patients will be diagnosed with these modes. But for a minority of cases where there is an obscure cause of the bleeding, not determined by these means, patients will require more specialist investigations, and these could be nuclear imaging modalities, or a capsule endoscopy, which is sometimes known as the pill cam. Patient swallows a special endoscope, and other rarer diagnostic tools which we can use.